Okay, hi everyone. Thank you so much for your patience. I think we're just going to get started. So, welcome to the 2023 Immunizations webinar series hosted by the Illinois chapter of the American Academy of Pediatrics. I'm Izzy Kritz. I'm an immunizations program coordinator here at ICAP. So thank you guys so much for being here. Today, Doctors Joyce King-Jones and Adiba Khan will be presenting on the social determinants of health and vaccine equity. Our session today is being recorded, and the recording and slides will be posted on our website later today. Please just use the chat box or the Q&A feature here to submit questions that you have during the presentation, and we will have time at the end to go over those responses. Here is our continuing medical education accreditation statement. So to receive CME, you're going to need to fill out the evaluation that will be sent to the attendees later today. And even if you're not seeking CME, we do still encourage you to complete that evaluation that gets sent out. Here is our planning committee and presenters, and no one involved with today's webinar had any significant conflicts to disclose. So with that, I'm just going to introduce our guest speakers today. So first off, we have Dr. Adiba Khan, and Dr. Khan is a clinical instructor in the McGraw Northwestern Family Medicine Residency at Lake Forest. In her role as core faculty, and with her strong interest in medical education, she oversees the residency, the curriculum and procedure clinic. She leads several curricular development and research initiatives, and her interests include comprehensive reproductive healthcare and the reproductive justice, resident feedback and point of care ultrasound, and social determinants of health and vaccine equity. Dr. Khan graduated from the University of Illinois College of Medicine and completed her family medicine residency at the McGraw Northwestern Family Medicine Residency at Lake Forest. During her residency training, she completed Northwestern Medical Education Clinical Scholars Program and served as chief resident. And then we have Dr. Joyce Jones-King. Dr. Jones-King is a clinical instructor at McGraw Northwestern Family Medicine Residency at Lake Forest. She is the course director for the community medicine curriculum, and a major part of her work is focused on health equity and addressing social determinants of health in racial, ethnic, minority communities, with emphasis on work in African American communities. Joyce has held the role as National Vice President of the Student National Association during medical school. Dr. King graduated from Rosalind Franklin University of Medicine and Science in Chicago Medical School and completed her family medicine residency at McGraw Northwestern Family Medicine Residency at Lake Forest. During residency, she was a member of the Northwestern Medicine Community Outreach Committee and the Task Force on Diversity, Equity, and Inclusion, as well as serving as administrative chief resident. In her spare time, she enjoys baking, gardening, and spending time with her husband and 3-year-old daughter. And so now I would like to turn it over to our guest speakers.
Thank you so much for those introductions. So we're really excited to be here today. So thank you for the invitation. Our learning objectives for today will define social determinants of health and their impact. We'll talk about screening and strategies to address those needs. Also look at some of the historical factors that contribute to medical mistrust in racial ethnic minority groups. So throughout this talk, you may hear me refer to the social determinants of health as SDOH, and racial ethnic minority groups may be referred to as RIM groups or RIM populations. And then we'll talk about vaccine equity a little bit, and we'll try and understand what goes into parents' decision-making when they are deciding to have their children vaccinated. And then we can talk about some strategies to address vaccine inequity in our communities. So throughout this talk, we'll actually refer a lot to COVID-19 data. This was a time where a lot of public health data was collected, and the impact of COVID really did uncover a lot of health disparity and exposed a lot of inequity in RIM populations. So persistent health disparities plus social determinant of health issues put members in RIM populations at high risk for COVID-19 infection. And we noticed the inequities early in the pandemic for the risk of severe illness and death. So RIM populations really did have to bear a disproportionate burden of COVID-19. So the CDC created a task force. They created an equitable response to be able to distribute vaccination into RIM communities. And really the goals of this were to reduce health disparity, foster meaningful engagement with community institutions and diverse leaders, and have a response to the pandemic that was culturally competent, and they wanted to reduce stigma around vaccination. So, we had a lot of data from adults, but what we learned was also children in RIM populations were disproportionately affected, and they also had risk of severe hospitalization and even death from COVID-19. So even 5 months, we're taking a look at some data that was from December 31st of 2022. This was 5 months after the vaccine had become available to young children. And we see that in racial ethnic minority populations, the coverage for children that are vaccinated with COVID-19 vaccine, at least one dose, was really low. There was lots of variation in race and ethnicity, and even depending on if people were located in urban locations. So when we look at this and we kind of take a deeper dive, there's lots of surveying systems that look at vaccination amongst RIM populations, and this is the data for children and adolescents 5 to 11. And this was a survey on parental intent to vaccinate. And the data is actually pretty similar when we move forward for teens. And the vaccine was available. There was an equitable way to increase uptake, and so we thought it would increase in that same manner, but unfortunately that was not the case. So this survey is interesting because when we look at what were the concerns that parents had in RIM groups regarding vaccinating their children, there were lots of concerns about confidence in the vaccine, so lots of vaccine hesitancy due to that, and then concerns about vaccine safety. So one thing I found surprising about this data is there was a report that a lot of parents had not heard from their primary care provider or their pediatrician a recommendation to vaccinate. So that was really shocking, and actually we'll talk more about that as we move through this conversation as one of the ways that we can intervene in this. And so here's the data for age 12 to 15-year-olds, congruent with the data for small children and adolescents, and then for teens 16 to 17. So really, when we took a look at this data, we became a part of a project through the American Academy of Family Physicians, and it was around addressing vaccine hesitancy in African Americans and racial ethnic minority groups. So being concerned about this data, at the local level, we really started trying to work to be able to come up with strategies to increase uptake in these communities since there was such severe disparity. When we look at the Illinois state level data, this is for adults. It's not broken down by age, but what we are able to still recognize is that there's a disproportionate uptake amongst African Americans, other RIM populations, and whites. We could not do this talk without taking a look at routine childhood vaccinations, because there's also some disparity that exists with routine vaccines. So, we know, just like with COVID-19, being vaccinated for things like polio and hepatitis, we know in RIM communities, there's higher incidence of more severe infections due to different social determinant of health concerns. And we notice that uptake is still low by race and ethnicity, and uptake is much higher in white and Asian populations. The AAP has a really cool interactive map feature on their website where you can take a look at the national vaccine data and you can compare rates by different states. And also you can even see states where there have been outbreaks for different things like measles. It's quite interesting. So I wanted to take a look at this model of children's health and some of its influences. There's many models out there. This is the kaleidoscope model. It comes from the National Institute of Health report that was released in 2004. And I like it because it demonstrates that child health is a dynamic process. So when we think about a kaleidoscope, I don't know how many people had the opportunity to use those in childhood. As you turn the kaleidoscope, it incorporates each color from the previous turn. So this is kind of similar in that way. And it shows us how there's multiple factors that go into child's health. And with each turn, as they develop from birth to early childhood, each of those components are incorporated from previously. I like this because even when we think about healthcare of adults in family medicine, we have to recognize that at one point they were children who were on this developmental curve, and all of the decisions that are made in their childhood, their social environment, policies and services that are implemented during that time can have an effect on the decisions they make in adulthood. And furthermore, the decisions they make for their children when they are adults. So with that, using that kaleidoscope model as a backdrop for our next few slides, this was an interesting survey that really talks about the impact of some of the social environment and access issues around COVID-19 vaccination. So it was a survey of white, Hispanic, and Black parents. And when we look at this survey data, we see that there are a lot of access related barriers and concerns in RIM populations. So there was concern about taking time off of work to bring children to become vaccinated. And not only that, what if they had side effects and then there would be more time subsequently having to be taken off of work by parents to care for children. There's concerns about financial access. How much will I have to pay out of pocket for this vaccine? We all understood that the COVID-19 vaccine was free, but when we think about what were the cumulative costs and what it could take for a parent to get their child to become vaccinated, that could be quite significant. And then concerns about obtaining obtaining your vaccine at a place where you trust, so a primary care provider's office. And when I look at this, I think about, in communities where there's lack of access to care and that inability to be able to be established with a primary care provider, this kind of how that influence plays out. You don't have a trusted provider that you've had that long-standing relationship with due to access issues. And then again, transportation issues. How will I get there? What if you have multiple kids that you have to take with you, small children? So all of these cumulative access issues are in the background, maybe creating some additional vaccine hesitancy. So what is the role of the healthcare provider? So this survey has some household income level data, and it was a survey of parents of children from 6 months to 4 years old, and 70% of these parents reported that they had not spoken to their pediatrician or another healthcare provider about the vaccine for their children. And we saw that families that had an income of $90,000 or greater had a higher likeliness of talking to their pediatrician about the decision to vaccinate. So there's lots of implications here. One I like to take away is that provider recommendation is so important no matter the community you serve. And then even more important, that recommendation coming from someone where you have a strong, established primary care provider relationship at a medical home is important. And again, this speaks to a little bit about access and some health equity concerns that we may have if you don't have the opportunity to have that access and form that longstanding relationship. Another piece of this data based on income regarding health literacy is what we're really looking at here. So majority of parents, about 55%, that have children under the age of 5, found some of the recommendations to be a little bit confusing that were coming from federal agencies. When we look at income level, 90K and above, they reported that it wasn't as confusing and they had a better understanding. So when I look at this, I can see at play some of the systemic disparity in education and the differences in health literacy depending on the population that you serve that can all be affected by social determinant of health concerns. So, a lot of what we do in medicine is downstream from the upstream battle of access to good education, access to stable income. So we have to also recognize that that's something that we have to combat when we're making recommendations about decisions for vaccination. So we know that social determinants of health affect total health. We've talked about some income level data. We've talked about transportation issues. We've talked about access to safe housing. Vulnerable populations will face these inequities. So how do we figure out where are the vulnerable populations? How do we quantify? How do we know if we're serving vulnerable populations? And we have to consider these access concerns when we're counseling. So the CDC has a social vulnerability index. This is accessible by all on the CDC website. You can look at your geographic area. I happen to pull up Cook County, and the score is calculated from 0 to 1, 1 being a high score. For Cook County, the vulnerability index is 0.8. So that indicates that this is a high vulnerability population. When we think about the population demographics for Cook County, we can consider race and education. And I took a deeper dive into this. And when we look at education, as we also saw some of the survey data that plays into decisions to vaccinate and understanding of health literacy, when we look at Cook County, 43.7% of white individuals that live in Cook County have graduated from a university, while 24.3% for Hispanic and Latino, and then 13% for Blacks and African Americans. And when we look at income in Cook County, the most common racial ethnic group that lives below the poverty line in Cook County are Black individuals, followed by white and then Hispanics. So when we look at this vulnerability index, I took a zoom into the area because Cook County actually, when we look at this, it's quite expansive. And the deeper the blue color that we see on the map, the higher the vulnerability in that area. So when we zoom into really the city of Chicago, we see that that's where the highest concentration of vulnerability exists. And as we've talked about some of those demographics, we have a high concentration of racial ethnic minority individuals within this geographic area. So what are we talking about here? We're talking about social determinants of health. So these are the conditions in which people are born to. This is where you live, learn, play, work, and grow up. So 80% of someone's health is not determined by what we do within the walls of our exam room, but it actually is determined by what happens outside of the care setting. So 40% is socioeconomic. So some of the concerns that we talked about, education, income, secure employment, different social supports, and actually community safety too. is one thing to consider. How can you exercise if you don't have a safe community to dwell in where exercise may be a feasible opportunity for you because you're concerned about gun violence or other issues in the community or lack of clean air? Which brings me to housing and environment. Access to clean water, access to secure housing, and even transit. And then, we counsel on behaviors all the time. We give anticipatory guidance. We counsel on reducing substance use with tobacco and alcohol. So when we look at some of the individual factors that contribute to social determinants of health, we also can't forget to consider cultural factors that play a role too. There's stigma related to your social determinant of health issues. And also, we have to recognize that racism and discrimination are also social determinants of health issues that affect children too, as they move through their developmental stages. So, who's most affected by this inequity? Health disparities tend to be concentrated in groups that have been historically disadvantaged, and that includes many racial ethnic minority groups. So I want to share this framework so we can kind of bring it back to vaccine hesitancy. And it takes a look at some of the reasons and associations that racial ethnic minority adults consider when they're trying to decide to get vaccinated, right? And this does kind of trickle down to children as parents are making these decisions. This is the social ecological model. It's commonly used in preventative care when we're thinking about some of the decision making that goes, some of the factors that contribute to decision making when people are making decisions about their health care. When we look at the broad categories within the inner circle, there's individual, interpersonal, community, and environmental. And then when we look inside of those at the outer circle, when we look at those broad categories a little bit more, we see what kind of plays into some of the decision making, and especially vaccine hesitancy. There's consideration of beliefs, discrimination, medical mistrust, bias, and even cultural and linguistic factors are at play too. So, when we look at this, there's historical context behind all of this that is at interplay, and it has longstanding implications. So when we look at the legacy of health disparities for a few racial ethnic minority groups that I wanted to talk about, we can start with African Americans, right? Medical mistrust goes all the way back to slavery in the 1700s when the father of gynecology performed and perfected his craft on enslaved Black women. There was no consenting process and there was no anesthesia being used. Also, the Tuskegee experiment. Many people know about the Tuskegee experiment because actually it was not that long ago. It was in 1972. It was conducted by the US Public Health Service. And this was at a time when we did have a known evidence-based treatment for syphilis, but 400 Black men were enrolled into this study, and they were enrolled to be able to study what the natural progression of syphilis was. And they were being told they were being treated for bad blood, but the treatment for syphilis was withheld from them. So many people know about this experiment, and it has a huge contribution to some of the medical mistrust that plays out in the exam room many often. And then here I have a picture of Henrietta Lacks. She's famous for HeLa cells. These were cancer cells who performed in a stem cell-like way. They were not stem cells. And they were the first immortalized cell line. And they have been really important in a lot of medical research. They've contributed to our understanding of HIV. They have been a part of cancer drug research and cancer research, and even some treatments. And also they were important in vaccine development. Her family has still not been compensated for the major contribution that she has made to the medical field. And then current day, we still witness persistent racism and social injustice in the African American community. Also like to discuss Native Americans. There is tremendous health disparity in the Native American community. Native Americans continue to die at higher rates than other Americans in many categories of preventable illness. So, this goes back to Native American treaties and the broken promises in the 1850s when colonizers were negotiating, and they promised payments and provisions to be delivered to Indigenous people, and still those promises were broken. And also we have to also recognize that during this time there was rampant sexual abuse and murder of Native American women, and the women in Indigenous populations had a major role in the family and some of the cultural practices. So this is very demoralizing. And then modern day, when we look at the Indian Health Service, so the Indian Health Service was created to fulfill treaty responsibilities to provide health care to Native Americans. And to this day, Congress is consistently underfunded the Indian Health Service. So this truly does force hospitals to not be able to deliver the level of care that they should, and it really does limit the services that are being offered. And then lastly, when we look at migrant populations or Latinx populations, present day, we've kind of seen a demonstration of disparity through treatment of migrant populations and having lack of access to safe shelter, proper education, and even health care. So, the impact of this discrimination does play out also in children as they are kind of progressing through their developmental stages. And then we may even recognize this later on as an ACE or an adverse childhood experience.
So at this point, we're going to shift gears to critically assess the data that we have regarding vaccine inequity among racial and ethnic minority groups. And we're going to be discussing actions that we can take to better understand and address these vaccine inequities, especially in the context of social determinants of health. We can begin by looking at data assessment tools to understand the disparities both locally, nationally, within our communities. And so vaccine data assessment in the United States is facilitated by these immunization information systems, or IISs. These are confidential population-level electronic databases that record all vaccine doses that are administered to people living within a given jurisdiction by the participating providers. CDC strongly recommends IIS based on evidence that their use increases vaccination coverage. As a point of care tool, an IIS can provide consolidated immunization histories that are up to date for use by providers in determining appropriate patient vaccinations. And then at the population level, immunization information systems provide aggregate data on vaccination delivery for use in designing and sustaining effective immunization strategies and for guiding public health measures. The CDC also created a data quality blueprint as a guide to help immunization programs enhance the quality of the data within the immunization information systems. And the CDC recommends that the data within immunization information should be available, complete, valid, and timely. These are tenets that would promote accuracy in assessing national, state, and local immunization coverage. And this is especially important to be able to track outbreaks and identify pockets of under-vaccination in a timely manner in order to target outreach and vaccine availability, similar to what we were able to do during the pandemic and targeted COVID vaccination efforts. A complete IIS would also support providers in assessing accurate immunization histories, assessing immunization gaps, and would also be capable of sharing data with other jurisdictions, because as we know, patients are often moving, and so having the ability to be more transparent with that data sharing would be tremendously helpful. To monitor progress towards achieving these data quality goals, the CDC annually surveys immunization program participants using the Immunization Information System Annual Report, or ISAR. Within this report, childhood, adolescent, and adult participation rates are reported. And so as you can see, in 2021, the report indicated that 98% of US children aged 6 years and younger participated in an immunization information system. So specifically, this included the number of children under 6 years of age with 2 or more vaccinations that were reported to this immunization registry. And on the next slide, you can see that among adolescents, 86% participated in an immunization information system. Despite these impressive statistics, it's important to recognize and be critical of some of the limitations of the immunization information systems that can lead to inaccuracies and pose especially challenges when it comes to assessing vaccine inequities, especially in REM groups. So to start, really, there's no national immunization reporting law right now or policy that guides IIS operation. There's a lot of variability among jurisdictions, which include states, counties, or cities, and laws within those individual jurisdictions govern these systems. And again, they vary substantially by that jurisdiction. So for example, only about 58% of jurisdictions in the United States require all immunization providers to report to an IIS, and about 39% require reporting for all age groups. Additionally, there really aren't any uniform mechanisms in place to enforce these policies, even in jurisdictions where there are reporting regulations. And then to complicate it further, there are varying consent policies at both the individual and practice level. So they range from mandatory participation with no opt-out option to opt-in participation only. So you can see how that can create a lot of differences with reporting rates among different jurisdictions. And so it can really skew data. There are also varying interpretations of federal laws that impact data quality as well. So HIPAA has a public health exception that allows the disclosure of personal health information to public health entities for the purpose of public health surveillance, investigations, and interventions. But despite this public health exception, there are varying interpretations of HIPAA by providers that limit the amount of information that healthcare providers think that they're permitted to share with an IIS. And this is erroneous, but again, is a barrier to more open access. And then FERPA, the Family Educational Rights and Privacy Act, this restricts the ability of schools to share information from a student's educational record without parental consent. So information on student vaccination status that's provided to schools in the enrollment process and to track compliance, that becomes part of the educational record and is prevented from being shared with that jurisdiction's IIS. So there's 2 separate systems attempting to collect similar data on the same population, and they can't directly or thoroughly communicate with each other. So again, creates a lot of excess costs and excess efforts in a particular community. And finally, one of the most significant policy challenges confronting these immunization information systems today is the inability to easily and universally share data among jurisdictions, despite well-established, agreed-upon technology and data exchange standards between the immunization information systems and then between them and EHRs. So current policies do not allow an IIS to share any data without establishing individual data sharing agreements between each individual entity. So for example, iCare, which is Illinois' IIS, has to establish a data sharing agreement with each elementary school, middle school, or high school to be able to share the data with them. So schools can pull data from the IIS. It's not true in the opposite direction. So that's an added burden to be able to have to create that data sharing agreement with each of those smaller entities. Furthermore, there really is an inability right now to share data seamlessly across jurisdictions. So this is particularly burdensome for neighboring states that have populations that receive care in one jurisdiction and live in another. So for example, we practice very close to the border of Wisconsin. And so we have folks that, across the border for their care, but we can't readily access their immunization registry from Wisconsin, and it makes it very difficult to care for them. All of these challenges demonstrate the need for a national immunization system policy framework. This would allow capture of vaccination data throughout the lifespan, enable data exchange across state lines. This would allow us to better estimate national vaccination coverage rates, identify pockets of low coverage, and then support provider needs in obtaining complete immunization histories as a point of care tool. A national policy framework would also help to ensure that vaccines are administered according to ACIP recommendations and that we're not duplicating vaccines. So for example, if somebody crossed the border from Wisconsin, they didn't remember if they'd gotten a particular vaccine. Oftentimes, if there is willingness and there isn't any additional risk with a second vaccination, it's given, but that's added cost and not necessarily with the benefit for the patient and the system. So next slide, please. Perfect. In addition to the inherent limitations of the immunization information system, there is limited data collection regarding vaccination rates among racial and ethnic minority groups. So at this time, this was really surprising to me, the CDC does not currently report race and ethnicity of vaccinated children. Only a handful of states report data in a way that allows for analysis of vaccine rates based on the racial and ethnic minority background among children. And then, so the best representation of this data that we have is actually just from a survey. This is a national immunization survey. It's a phone survey used to monitor vaccination coverage among children and teens. So cell phone numbers across the United States are randomly selected and called to enroll one or more age-eligible children or teenagers from the household. And then the parents or guardian of that child is asked to provide consent to contact their provider. And when that permission is granted, a questionnaire is mailed to the vaccination provider in order to corroborate the information that the parent had given. So the data collection for the first survey actually began in April of 1994 to check vaccination coverage after a measles outbreak in the early 90s. And so we've used it ever since then, and it was very helpful actually to gain a lot of data during the pandemic. So there was a National Immunization Survey Child COVID module that was created. And it was used to assess racial and ethnic differences in COVID-19 vaccination coverage. And they assessed a lot of behavioral factors as well, parental intent to vaccinate, behavioral and social drivers of vaccination among children and adolescents. So that is a lot of the data that we pulled. Again, that's the best that we have at this point. And so you might have seen this interactive map on the AAP website. This is a very helpful tool, as Dr. King previously mentioned, to look at data regarding immunization rates by region. But again, I want to point out to you that the data regarding the REM status, the demographic info, is actually obtained from a survey. So it is that subjective reported data by the parent or the guardian, and it is not directly reported by, from the immunization information systems that pull that objective data. So you can imagine the inherent limitations of a survey method. They only involve a sample of the population of interest. This is just inherent to any survey. Some of the sampled individuals may not respond to a survey. Some of the population of interest may not be covered by the group from which the sample was chosen. In addition, there are problems associated with the interviewers, the respondents, the questionnaire itself. For example, if some questions are unclear or the respondents have difficulty in recalling answers about, vaccine counseling that was done at a particular visit. And then finally, we should think about the ways in which social determinants of health, including access, health literacy, language and technology barriers from that educational background. All of these can really impact the data. And again, I want to remind you, these are cell phone numbers that were used. And so if somebody is working 2 jobs, somebody is, has a language barrier and they're not going to be able to answer a phone call, or has, cost-related barriers to be able to have a longer conversation, all of these can skew the data and limit our ability to assess that vaccine status in REM groups. Within Illinois, iCare is a robust immunization information system developed by the IDPH. This was implemented in 2007, and there's a lot of really great features of iCare that actually follow that blueprint data quality initiative by the CDC. So iCare allows providers to access immunization records of Illinois residents from across the state. There's an ability to import vaccine records into EMRs directly from iCare, as long as that interface is working well. Age-appropriate vaccination reminders are readily available then once that interface is completed. There's population health management abilities if you can pull that information into your EMR and be able to assess that. And then it is an opt-out. There's just an opt-out option. So everybody is default enrolled into iCare. So it really increases participation rates. So Illinois has really made great efforts to increase participation in iCare. For example, practices must be enrolled in iCare to administer COVID-19 and VFC vaccines. And again, for those that may not be aware, VFC, or Vaccines for Children, is a federally funded program that provides vaccines at no cost to children who might not otherwise be vaccinated only because of their inability to pay. And so because of iCare, thanks to iCare, we were able to have robust COVID vaccination data in Illinois. Furthermore, in Illinois, you all may be very familiar with this, an initiative called IVAC, or Illinois Vaccinates Against COVID-19, was implemented to support providers in improving COVID-19 immunization rates. So they put out a lot of really great resources in a very timely manner to support providers. Some resources include vaccine boot camps, learning collaboratives, implementation assistance, outreach materials, DIY toolkits. So really a lot of really great resources that could be, picked based on the practices or providers' needs. In addition, they sent out these vaccine report cards periodically to allow providers an understanding of the local vaccination rates and patterns. So on the left, you can see data regarding vaccination rates among different age groups in Illinois reported from iCare. But on the right, you can see CDPH, they obtain data regarding demographics and racial and ethnic minority status. And so that data was further broken down. And so it was really, really helpful for those that lived in that Chicagoland area and practiced there to be able to assess those patterns and really make the initiatives that they needed. Similar to other patterns, you can see that vaccination rates among Black patients were the lowest in all age groups across the Chicagoland area. And then in the following slide, data is actually broken down according to counties as well. And so you can see here that Lake County performed slightly better than Cook County in all age groups, although again, this data was not reported according to REM status, but again, helpful in assessing the patterns across the state. So as Dr. King explained, we are part of a QI initiative through the American Academy of Family Physicians to improve immunization rates among African American adults and racial and ethnic minority groups. We try to better understand our clinic level data to be able to intervene appropriately. And we ran into several barriers. So we have Epic as our EHR, and within Epic, we used the slicer dicer functionality, which some of you might be aware of. And we also enlisted the help of our IT team. So despite all of this support, We found several barriers to be able to accurately assess vaccination rates. Most notably, we found system PCP attribution errors, which impeded our ability to assess, population health level data at the provider level. And then there's also really no great way to capture reasons for vaccine refusal within EPIC, so that when there is, team-based care, it's really difficult to further conversations at subsequent visits when you don't know what the conversation was previously. So providers really have that added burden to document, those conversations. Whereas it could be a very easy implementation to put in a little button saying, hey, this was what happened this time, or something like that. Despite the challenges with data assessment at our clinic level, we were able to find and implement several evidence-based interventions to address vaccine inequities through an SDOH and REM lens. I wanted to highlight a resource that the CDC put together regarding strategies to reduce vaccination disparities among racial and ethnic minority populations. While this resource was created specifically to improve COVID vaccine rates, the strategies apply to really any vaccine in all age groups. So one of the most important factors, as we discussed in improving vaccine acceptance, is a strong recommendation from the provider. One study actually looked at factors that impacted HPV acceptance rates among adolescent females in the US and found that a parent who receives a recommendation from their child's healthcare provider is 4 to 5 times more likely to get the HPV vaccine for their child. So it really is an impactful measure. So when conversing with patients and families, providers really should use a presumptive approach in which you assume that patients and parents will choose to vaccinate. So you might see something like, your child needs the DTaP, HIV, and hepatitis B shots today, as opposed to a less effective method, which is called the participatory approach, one that presents parents with a decision to make, in which you might have said, have you thought about the shots that your child needs today? So making that, kind of a presumption and using that language really is more effective. Additionally, providers really should enlist motivational interviewing techniques to understand patient and parent perspectives and make patient-centered recommendations. So a good way to invite conversation in a non-judgmental fashion is, I'd like to understand what makes you say no today, if you notice any hesitancy. It really, again, respectfully and inquisitively kind of invites that conversation. Another important strategy to address vaccine inequity is workflow consistency in order to reduce missed opportunities. So providers really should make a strong recommendation at every visit and vaccinate at every visit, not just at well visits. Standing orders are also a really beneficial intervention. Standing orders authorize nurses, pharmacists, and other healthcare providers, where allowed by the state, to assess a patient's immunization status and administer vaccinations according to a protocol most often approved by the institution or the provider without direct provider involvement at that time. And then finally, vaccination reminders for providers are really effective. For example, within EPIC, there's that functionality called the care gap. So that's readily available. It's very visible. When these are readily available and visible to all of the folks in a clinic, they promote a culture of vaccination within the practice. So it really is an evidence-based method to improve vaccine inequities. So as we discuss the impacts of strong provider recommendations to address vaccine hesitancy, I'd really like to highlight this survey again that we had mentioned earlier by the Kaiser Family Foundation. It demonstrates the need for, again, consistent and equitable conversations among all REM groups to achieve progress. So we really need to standardize these conversations and make sure that we're bringing them up at every visit, despite any biases or preconceived notions or constraints that we might have at that visit, because it really makes a difference. That little nudge is effective. So then, as outlined by Dr. King, medical mistrust among REM groups carries a long history. It's quite prevalent, and it's an important factor in driving vaccine hesitancy. There are strategies identified at multiple levels to address this. At the provider level, there need to be culturally competent and sensitive conversations. And then at a larger scale, a lot more work needs to be done to increase racial concordance among healthcare providers and the communities that they serve, and just overall medical workforce diversity to be able to have more of those trusted messengers delivering these messages and recommending the evidence-based care that we've identified at this point. Another challenge for providers, especially within REM communities, is combating misinformation. So patient attitudes toward vaccination, in particular, the belief that the likelihood of a serious adverse effect or adverse event following immunization is more likely than the projected benefits of vaccination. This is often a large problem in REM groups that drives vaccine disparities. So providers really need to strive to increase vaccine confidence, although vaccine myths are difficult to combat. So as we noted previously, poor health literacy is ultimately a social determinant of health, and medical information really needs to be shared in a patient-centered manner. Some best practices include tailoring the message to the audience. So we all know that perceptions about vaccines differ based on political party, race, age, geography. So we really need to be careful in avoiding judgmental or demanding terms, and acknowledging concerns or skepticism and offering to answer those questions, again, in a non-judgmental, shared decision-making type of a manner. Explaining the benefits of getting vaccinated and not just focusing on the harms of skipping the vaccine is really important. So you might say something like, getting the vaccine will help keep you and your family safe, rather than calling it the right thing to do and dwelling on consequences. In addition, refer to the people behind the vaccine. So the medical experts, the researchers, the doctors, as opposed to, the science, the health, big pharma. These, the prior have been received as much more trustworthy when it comes to acceptance of vaccination recommendations. So in addition to these provider and practice level interventions, there's been several programs at the federal level, and again, one of which is the VFC program. So children through the age of 18 who are either Medicaid eligible, uninsured, or underinsured, and then of American Indian or Alaskan Native descent are eligible to receive these vaccines in order to reduce costs, the effects of cost as a barrier to vaccination. In addition to the VFC programs, providers really should familiarize themselves with fee schedules for possible, adjustments, and then the state's CHIP program, so the Children's Health Insurance Program, and other vaccine-focused programs available within their jurisdiction in order to really, overcome cost as a barrier, because there really is a lot of help when it comes to that, especially with routine childhood vaccinations. So we come back to this framework because, we discussed a few strategies on how to decrease racial and ethnic disparities in vaccination, but you can see how this is a very complex topic, and we have a lot more work to do when it comes to adequate data assessment and reporting so that we can really understand the problem and make effective solutions. So there really needs to be a broader use of multi-level interventions addressing those individual concerns as well as those structural contextual barriers to access in order to increase that routine vaccination uptake in communities of color. So implementation at a larger scale is needed to evaluate and demonstrate change, and it requires dedicated resources and focus from many levels: federal, state, local public health officials, individual healthcare providers, and community partners. Really, these interventions should be guided by early and ongoing investment by those communities, because as we understood earlier, social determinants of health really do include those communities, those teachers, those community leaders. And so that can really help to maximize those benefits when the message comes with them in concert. Only really through these efforts can there be really tangible advancements in reducing the longstanding vaccine inequities that we've seen that have resulted from a national legacy of structural racism. So really complicated, to say the least. And finally, here are a few resources in addition to those that were listed on the slides that we've referenced for more information. And then we'll welcome any questions.
Thank you guys so much. And now we're just gonna open it up to any questions that people might have. So we'll just take a few minutes and wait for any questions to come on in. Okay, so it does, oh, yeah, I don't think that we have any questions coming in. But these are our upcoming webinars. Thank you guys all for being here. That is all from us today.
Thanks for your time and for the invitation.
Thank you all so much. Take care.